Oh, we have one? Oh, Senator O'Shea? Okay. Senator O'Shea, would you like to introduce our bill introductee?
Yes, thank you, Mr. Chair. So this is special for me. This is a constituent who reached out last year, and we've been working together for a year on this bill, so I let her introduce it, and hopefully we'll hear more later.
Hildebrand and Senator O'Shea, thank you for allowing me to be here this morning to present. My name is Sarah Hale, and I would like to introduce a bill to you all that is near and dear to my heart. The bill is 2022 RS 2373. This bill will speak to removing the term hearing impaired, and then replace it with the appropriate term of hard of hearing or deaf. And why that term hearing impaired is very offensive to the deaf community is that it really hurts us. We see it used very often, and it's actually very offensive. It has a negative connotation, it includes judgment, and when other people use that term, hard of hearing, it's a more positive that it is all-inclusive of our language, our communication, and our culture. So please understand that this bill is not just something that has come up recently. Hearing impaired has been used for many, many years and throughout my life, and I have heard that term. My parents were deaf and they were referred to that term, and it is still and continues to be a very negative connotation. So I would ask you, please consider that bill 2022 6373 and to change the term. Thank you.
Committee, you've heard the request for the bill introduction. Donola, could you give me that RS number again, please? For RS 6373? Okay, so the request is for RS 2373 for a bill introduction. Committee, without any objections, we will introduce that bill as a committee bill. Not seeing any, that bill is introduced. Thank you very much.
And thank you so much.
Do we have any other bill introductions before we move on to our presentations? Okay, not seeing any. Committee, we will now turn back to a continuation from yesterday. This one will be presentations on certified registered nurse anesthetists. So for those of you listening online, that's about as good as you're going to get from me on that word. So we're not going to try again. First, conferee. And conferees, I would like to remind you, we are time sensitive committee. There is a committee that meets after us, so we are confined to only 10 minutes for the three conferees apiece. So you have 10 minutes for each conferee. Elisa Blau, President of the Kansas Association of Nurse Anesthetists. And for future references, we're just going to say CRNAs. Elisa, welcome to the committee.
Members of the committee, thank you for your time today. My name is Alyssa Blau, and I am the current president of the Kansas Association of Nurse Anesthetists. I represent more than 900 CRNA and SRNA members in the state. I appear before you today to discuss a letter which was approved on June 11th in 2021 by the Kansas Board of Healing Arts regarding delegation of anesthesia services to anesthesiologist assistants, or AAs. These providers are not authorized nor recognized in statute for licensure in Kansas. This letter effectively acted as a substantial policy change approved by the Board of Healing Arts, but without public notice, testimony, and without going through legislative process. Since 2017, there have been 3 bills that have been introduced to the Kansas Legislature, which would have established the licensed profession of anesthesiologist assistants in the state. While multiple legislative committees have held hearings on those bills, including an interim legislative roundtable, no action has been taken on the matter to date. The timing of the Kansas Board of Healing Arts letter can be summarized as follows. The Kansas Legislature adjourned on May 8th in 2021, and 10 days later, on May 18th, the Kansas Society of Anesthesiologists sent a letter requesting delegation of AAs to the Board of Healing Arts. And the Board of Healing Arts approved a letter on the same date as their June 11th meeting. During this June meeting, the board discussed the subject of anesthesia services, including a prospective third anesthesia provider and delegation of care to an unlicensed anesthesia professional. During this limited half-hour period, only one perspective was allowed to speak, and it was delivered by the very same organization which requested the letter. We are of the opinion that if the association or other vested parties have been granted the opportunity to speak before the board and provide a broader view of anesthesia care, it is unlikely the board would have come to such a decision. Despite this view, our request to discuss the matter further with the board or even consideration of revising the June 11th statement was denied. The only action since the board's June meeting was the issuance of a brief statement by then Executive Director Tucker Poling, which said the board was merely stating whether AAs may practice in Kansas under the board's jurisdiction. We expressed concern that the Executive Director's comments oversimplified an incredibly complex matter without context to the multi-agency concept of delegation. The board also expressly avoided providing guidance on important aspects such as a physician's discretion regarding delegated individuals' competency. The statement was explained to not be construed as a clinical or professional recommendation or lack thereof, or an expression of preference for or against the professional services of CAAs. In our immediate response, we provided direct statements which indicated the Board of Healing Arts had taken action to formally recognize AAs in the state. Please see Exhibits 1 and 2. The American Academy of Anesthesiologist Assistants immediately sent out notification of practice rights in Kansas to its membership and posted it on social media. We cautioned the Board of Healing Arts that even referring to AAs could be misleading and result in public confusion, and which has proven true and is shown in Exhibit 3. Our response also noted the statement lacked consideration of the wider regulation of anesthesia services, such as the Kansas Department of Health and Environment's regulation of Kansas hospitals that would not allow for such delegated practice when considering public health, safety, and welfare. Also, there was no consideration of more complex matters, such as the handling of controlled substances by an unlicensed provider. Yesterday, the Board of Healing Arts noted that they have other unlicensed providers under delegation, which included scrub techs. Anesthesia is a much different scope of practice than that of a scrub tech, which includes using very powerful medications and controlled substances. The lack of consideration of other regulations likely explains why the statement concluded that the board is of the belief that the protection of the public is best served if further legislative attention is given to the licensure of AAs in Kansas. Some vague and misleading information has continued to be used in justifying the actions of the letter. And however, I would like the record to reflect the facts of the matter. For instance, the stated reason for proposing a third anesthesia provider has most often centered around the perceived anesthesia shortage in the state. The fact is, the state's 31.8 anesthesia providers per 100,000 residents places us well ahead of the national average of 24.9 providers per 100,000 residents. This has increased from 2019 to 2021, and Kansas remains higher than all surrounding states in anesthesia providers per capita. We have also made proposals for compromise with real action. Our first was to expand KU's and Newman University CRNA programs, which has already increased output by almost 50% to date. Secondly, we offered to work with the Kansas Society of Anesthesiologists to increase anesthesiologist residency slots. This proposal was not accepted. And our association also offered to collaborate with the Kansas Society of Anesthesiologists and other stakeholders to assist any hospital that may be having an individual problem with staffing. This proposal was also not accepted. The Board of Healing Arts was advised that AAs and CRNAs have equivalent educational training and acute care experience. This is an objectively false statement, And the fact is, there is a fundamental difference in our experience, training, and skill level. At the most basic level, this is shown simply as CRNAs are allowed to practice independently and AAs are not. The Centers for Medicare and Medicaid Services, or CMS, prohibits AAs from billing Medicare for non-medically directed services, and AAs must only be medically directed in order for reimbursement. This is in direct contrast to that of CRNAs. CMS further clarified the distinctions between CRNAs who may practice autonomously and AAs who must be medically directed by an anesthesiologist in order to bill for Medicare. This action confirms what we already know. CRNA and AA educational preparation and services are not the same, and Medicare recognizes them differently. Thank you for your time today, and I will stand for any questions at the appropriate time.
Lisa, thank you. And I think since we have different conferees representing different entities, we'll go ahead and open up for questions for you right now. Committee, Senator Thompson.
Thank you, Mr. Chair. Thank you, Alyssa. Those several proposals, did they give you any reason why they were denied, why the proposals to work with the anesthesiologists and expand the care?
I was not present at those conversations, but that information has been passed down to me from previous presidents.
Okay, thank you.
Senator Petty.
Thank you, Mr. Chairman. And Elisa, thank you for being here today. You mentioned about the statement about a critical shortage and that we, according to, I'm not sure what it's according to, but that we have a higher number of anesthesiologists or anesthesiologist providers per capita per 100,000 than other states. And what is that? What's that figure come from? From what?
It comes from the government CMS statistics. We can get you a copy of that if you'd like.
Okay, thank you. And just to follow up on that, so it was mentioned, I can't remember if it was in testimony or if it was in a side conversation about that there are multiple postings across the state for a need for anesthesiologist providers.
That's normal for across the U.S. to have job openings. And there are over 55,000 CRNAs available nationally to fill those spots. And we work very diligently to help fill those needs where necessary.
And lastly, Mr. Chairman, you mentioned about the difference in reimbursement.
Yes.
For provider services. Could you expand on that?
Yeah, so anesthesia billing in of itself is a very complex nature. So with the CMS regulation that allows CRNAs to bill independently of an anesthesiologist, it's under QZ. And actually, Kansas has the highest rate of QZ billing in the entire nation. We bill anesthesia services around 65 to 70% QZ, which means that we are able to meet the guidelines for TEFRA without jeopardizing any hospital's position for criteria for reimbursement.
Senator Baumgartner.
Thank you, Mr. Chair, and thank you, Alyssa, for being here today. Could you share with us, you mentioned that Newman University as well as University of Kansas both offer the CRNA program. Are there any institutions of higher ed in the state that offer the AA program?
Not currently.
One other thing I wish you would share, because I remember that it was included in testimony in prior years, those bills that had been before us. Share with us that requirement before you can even be admitted into a CRNA program.
Yeah, so you must hold a registered nurse license and have a bachelor's degree, 4-year bachelor's degree. And then you have to have a minimum of 1 year ICU experience. On average, we have about 4.5 years of ICU experience for admittance. And Dr. Donna Knight will be speaking about our CRNA programs, I believe, next. She can elaborate probably more on that for you.
And share with us what that requirement is for AAs to get into the program.
They have, I believe on the UMKC website, it recently said that they have to have a bachelor's or degree already or shortly before applying.
Thank you very much. Thank you, Mr. Chair.
Senator O'Shea.
Thank you, Mr. Chair. I asked a couple questions yesterday, so I wanted to ask them today, and that one covered my one about kind of the schooling, the educational differences. What is the difference in pay?
Currently, if you are in an anesthesia care team model, they are roughly about the same. However, if you get out into more of the critical access hospitals, the CRNA pay will be greater. And that's simply because you are not paying the higher salary of an anesthesiologist along with a CRNA or an AA.
Thank you. And one more. Why did the AA, so CRNA program was there first. Why do you think the AA program came about?
It came about in the 1960s. However, I will let them speak to why it came about. CRNAs were one of the first people, or first providers to kind of really specialize in the field of anesthesia. We've been around since the late 1800s. We were charged with providing anesthesia from surgeons because they knew nurses would take very vigilant care of their patients while they focused on the surgery. So they were trained to provide the anesthetics while the physicians could do the surgery. And that's how we got started.
Senator Gossage.
Thank you, Mr. Chair. A couple of questions. So when did anesthesiologists come about?
They came around shortly after nurse anesthetists were established.
So they have been functioning together for many, many, many years.
Yes.
And they both do the same job, would you say?
Yes.
Training similar?
Yes.
So an anesthesiologist is considered a medical doctor?
Yes.
Correct?
Anesthesiology is considered practice of medicine, and anesthesia or anesthesiology is considered the practice of nursing.
Okay, but they both do the taking care of the patient,
The same way.
administering
The
anesthesia,
anesthetics.
right?
Yep.
So then I guess what I'm trying to understand from what we heard and testimony that I read yesterday as well is that it seems that there is a conflict as far as job placement, that you would see the AA or CAAs coming in and trying to take over jobs that are currently held by CRNAs. Is that what I'm hearing you say?
Well, it'd be anti-competitive. We cannot oversee an AA, and therefore, if you have two entities that have equal skill and equal providing ability, and one has an assistant below them and the other one does not, that's anti-competitive. And they can have control over the market then.
Okay, not quite understanding that because it's that they choose to have an assistant, just trying to understand. So if you guys are considered equal in the performance of your job, and then the anesthesiologist decides he wants to hire an assistant, and then jointly they're paid about the same as what you receive, what you're saying is that you can't hire an assistant?
No,
Okay.
no. If we could supervise AAs, that'd be a different talking point for a different day. However, that's not the case. And our students are not able to be trained by AAs, so any AAs that are in a room at a university or a learning facility for one of our students, as you'll hear from Dr. Knight, is they are not able to have that learning opportunity in that room.
Thank you. Thank you, Mr. Chair.
I have a quick question for you. Can a CRNA do their job without a anesthesiologist present?
Correct.
Can a AA?
No.
Okay, thank you. Any further questions? Okay, not seeing any. Thank you for your testimony.
Appreciate it.
Committee, our next presenter is Carol Moreland, Executive Administrator of the Kansas State Board of Nursing. Carol, welcome to the committee.
Thank you very much. Good morning, Chairman Hildebrand and committee members. I'm Carol Moreland. I'm the administrator for the Kansas State Board of Nursing. As the Kansas State Board of Nursing, we regulate the CRNAs. Okay, we have about 73,000 licensees presently, which includes LPNs, RNs, advanced practice, of which the CRNAs are one role of the advanced practice nurses in the state of Kansas. We have about over 1,200 licensed CRNAs in the state of Kansas presently. We have been regulating the CRNAs since 1986. What I wanted to share with you today is some information about admission requirements coming into the programs. There is significant difference here, and I think there was a question asked earlier of Alyssa, and so hopefully the information that I'm presenting may kind of clear some of this up a little bit. I just felt it was very important that you know the differences that someone must have before they come into the two programs, because they are very significant, okay? The CRNAs receive more specialized education, and they are more competent than the certified anesthesiologist assistants before entering their anesthesia education program. CRNA programs require an applicant to have a 4-year degree, a BSN. They need to have an active RN license. They need to have anywhere from 1 to 3 years of intensive care or critical care experience. I think you heard from Alyssa that average is more than that. They need to have a GPA of 3.0 or higher. They need to have certifications that include basic life support, advanced cardiac life support, and pediatric advanced life support, along with recommendation to have a critical care registered nurse certification. So I just want to briefly overview those so that you can kind of understand those and what's included in those a little bit more. A BSN graduate completes approximately 125 credit hours of study. These include, the first 2 years are typically general education, prerequisite courses before they're accepted into the nursing program. And then the last 2 years are going to be their nursing courses. The general education prerequisite courses are approximately around 58 credit hours. They include communication courses, both writing and speaking, which is very important for nurses, psychology, sociology, human or child development, college algebra, college biology with a lab, general chemistry with a lab, microbiology with a lab, human anatomy with a lab, human physiology, nutrition, and statistics. The nursing courses then in a BSN program are approximately 67 credit hours, and they include courses in the following: a foundations of nursing. What's nursing all about? So they can kind of understand that. That's usually the first course that they're going to take. Nursing assessment. Nurses have very strong assessment skills. So they start that in nursing school. Basic nursing interventions, pharmacology, research and evidence-based nursing, so they can understand why we do what we do based on evidence. Mental health nursing across the lifespan, adult nursing, gerontology nursing, pediatric and family nursing, community nursing, maternal newborn nursing. They have a preceptorship, and then they have professional development. Nursing education contains both didactic and clinical courses. So they do have a very strong clinical base when they graduate from a BSN program. So once they've graduated then, they have to pass a national licensure examination before licensure. It's called the NCLEX. It is a national test. So the content of that is organized into 4 major areas. They include safety and effective care environment, health promotion and maintenance, psychosocial integrity, and physiological integrity. And then they also have some fundamental processes that are included in there. That's the nursing process, caring, communication and documentation, teaching, learning, and culture and spirituality. So they've graduated, they've passed their licensure exam, and they're licensed. So another requirement is that they have at least 1 year of critical care experience. This is very vital before coming into a CRNA program. Nurses working in critical care are very highly trained and have specialized competencies. They care for the sickest of the sick in the institutions. Patients in ICU need a higher level of care, and ICU nurses must have very strong critical thinking skills to react appropriately whenever a patient's condition changes, which can be in an instant. A patient in ICU is often on a ventilator, intubated, and can be on several life-saving medications that are administered intravenously. Specific competencies of an ICU nurse can include monitoring and evaluating the patient's condition, identifying any subtle or sudden changes in the patient's condition, administering life-saving medications, informing the physician of the patient's condition and any changes, monitoring the patient's lab results, EKG results, and other diagnostic test results, assessing a patient's level of pain and sedation, and then setting up and monitoring some very sophisticated medical equipment and devices. Those could include ventilators, oxygen delivery, pressure lines, multiple infusion pumps. The ICU nurse also provides emotional support to families and the patient during a time that is very stressful and very uncertain for them. ICU nurses often also respond to other emergencies in the facility when a patient's condition rapidly deteriorates, so they must have knowledge of all the emergency life-saving interventions and respond rapidly as part of a coordinated team to save the patient's life. So just briefly on certifications, I talked about basic life support, advanced cardiac life support, and pediatric life support. Basic life support would be for like what your first responders get. It is your foundation, okay, about how to respond in an emergency. When someone experiences cardiac arrest, respiratory distress, or an obstructed airway. Your advanced cardiac life support knowledge and skills builds on top of that, okay? It would include recognition and early management of respiratory and cardiac arrest, life-threatening heart arrhythmias, airway management, pharmacology, and management of an acute coronary syndrome and stroke, and then effective communication and teamwork as part of a resuscitation team. And then PALS is basically a lot of the same, except it's with your pediatric patients. And then the last thing that I mentioned was the critical care registered nurse certification. It is a specialty certification for nurses who provide direct care to acutely and critically ill patients. An applicant for this must have an RN or an advanced practice license and meet clinical practice hour requirements before they can take the exam. The certification exam content is 80% clinical judgment and 20% professional caring and ethical practice. So the clinical judgment content, that's 80% of it, covers every system that you would see with a patient. I provided an overview of the admission requirements for admission into programs that prepare CRNAs. Just as a comparison, the admission requirements for a Master of Science in Anesthesia program in Missouri that educates and trains anesthesiology assistants includes the following: biology with lab, general chemistry with lab, organic chemistry 1 and 2 with lab, physics with lab, biochemistry, human anatomy, physiology, statistics, mathematics, and a course in medical terminology. The applicant must have earned or will soon earn a bachelor degree or higher. There's very extensive specialized nursing knowledge before admitted to a CRNA program, and that is very vital. That leads to a more competent practitioner. The Board of Nursing, our mission is to protect the public by having competent practitioners out there. I know that all of us here also want to protect the public as much as we can. CRNAs are more competent than certified anesthesiology assistants coming into the program because of their extensive specialized nursing knowledge that they have as a foundation to be admitted. They will then obtain their doctorate in nursing anesthesia practice degree. They will pass yet another national certification exam.
Carol, thank you for your testimony. Committee, do we have any questions? Senator Thompson.
Thank you, Mr. Chair. Thank you, Carol. I think you said there were about 12,000. You mentioned the number 12,000. Was that the number of CRNAs in Kansas?
That's 1,200.
Or 1,200, okay.
Sorry, if I said 12,000, 1,200.
And it's early, I could have misheard. I know in some hospitals, there are some shortages of nursing staff. Some are actually quitting because of the vaccine mandate. Can you speak to what the situation is with the CRNA group with regard to that?
Well, I can't probably hit that quite as well as just registered nurses. I think Alyssa probably kind of touched on a little bit of that. It is very true. We are losing nursing. And unfortunately, it has to do with more just than the vaccine mandate. You know, the last 2.5 years have been very difficult for nursing. And they're very tired, they're very frustrated, and now they're getting sick themselves when they're trying to do everything that they possibly can. So yes, we are concerned that we will be losing nurses. You know, we do not have the experienced nurses coming in to take their place because graduates are never as experienced coming right out as, you know, someone who maybe has 10 years of experience. You know, I think that's something that's going to help a lot is the legislature passed the Nurse Licensure Compact a few years ago. So we are one of 38 states in the nation that are part of that Nurse Licensure Compact. And as such, we can issue multi-state licenses. And like if we issue a multi-state license in Kansas, they can go to any of those 38 states and practice as an RN. Now, this does not include advanced practice. So that has been extremely helpful in the pandemic. You know, I think it really helped before, but what's happening now is it's across the whole United States. So we can't move from one part of the United States to another as far as bring nurses because it's basically everywhere.
Okay. Thank you. Thank you, Mr. Chair.
Senator Gossage.
Thank you, Mr. Chair. I understand that CAAs are allowed to practice in Missouri. Is that correct?
That's my understanding, yes, yeah.
How has that relationship been with the CRNA population and the CAAs in a state that's already doing this? How's that working?
I don't know that I can address that. I'm sorry. You know, I kind of stick with what's going on in Kansas as far as, so I am sorry, I can't really answer that question.
Thank you.
Carol, I've got a couple of questions for you. So a CRNA is a nurse. Mm-hmm. Is an AA a nurse?
No.
Is a surgical technician a nurse?
No.
So a surgical technician is able to function because of why?
The physician delegates to that surgical tech some duties that they can do, but the physician is actually delegating that to an unlicensed person.
Okay, thank you. Mm-hmm. Senator O'Shea.
Thank you, Mr. Chair. My question is if I was a student coming out with a 4-year degree, it would be a lot easier to go the AA route, correct?
Yes,
It's
as far as
simpler.
the preparation, yeah.
Right. So I just keep wondering, how were these programs created without collaboration between nurses and physicians?
A lot of questions about that. There's always been, you know, not always the best collaboration. Yeah.
No. One more from Senator Thompson.
Thank you, Mr. Chair. Has the virtual learning, with all of this craziness the last 2 years, has that impacted the number of CRNAs coming out and into the workforce, or are they working in person regardless of the situation. I know the hospitals have some fairly strict rules, and I know I know some nurses personally that are RNs personally, and they feel pretty stretched thin, and I just curious about that situation.
As a whole, clinical education has been impacted when COVID hit. I can just tell you for nursing, a lot of the hospitals closed down the ability to bring nursing students in to do clinical, which definitely impact the nursing programs. They had to switch to like virtual simulation as much as possible, but we do not, our regulations do not require, or do not allow 100% of their clinical education to be done virtual simulation. They need to be with patients. I mean, you can only simulate so much. Well, the good thing is a lot of that is starting to open back up now, you know, whether it be with vaccines or whatever. You know, I think everybody feels that they know a lot more about COVID now and kind of what they can do and what they can't do, where before it was just, we got to quit doing everything, you know, and stuff like that. So they do have to still have clinical education.
All righty, thank you. Thank you, Mr. Chair.
Okay, not seeing any more questions from the committee. Carol, thank you very much for your testimony. Committee, our next conferee is Donna Knight with a bunch of acronyms behind her name. MS, DNP, CRNA, and she's the department chair for the University of Kansas Nurse Anesthesia Education. So, Donna, welcome to the committee.
Thank you, Chairman Hildebrand and committee members. I appreciate the opportunity to speak with you today. I have been a lifelong Kansas resident. I grew up in a very small town, 250 people, so I understand rural Kansas very well and work and, of course, live in the Kansas City area now. I have 3 degrees from the University of Kansas, and I hope my voice holds out. I was at the basketball game last night, did a lot of cheering for the Jayhawks. I have been chair of the department since 2008, and basically what I want to do today is speak on behalf of nurse anesthesia education and the impact that any AA credentialing and work in Kansas would have, not just on the students in the KU program, but other, they're called SRNAs, Student Registered Nurse Anesthetists, so when I say SRNAs, that's who I'm referring to. I do want to mention that I am not representing the views of the University of Kansas. I do work at the University of Kansas, and my expertise has been in nurse anesthesia education for a number of years now. The KU program has existed for a very long time, for about 55 years. Started out as a certificate program and has transitioned over the years and is now a doctorate program. All nurse anesthesia programs are now doctorate programs. This was as of January 1st, 2022, or they were no longer allowed to admit students. So we have been a doctorate program since 2012. That was the year that we admitted our first class in a clinical doctorate program. And over the years, we have increased our class size tremendously. I graduated in 1993, and there were 11 in my class. During my time on faculty, we had 20 to 24 students in each class for quite a while. We certainly saw the need to graduate more CRNAs, and we had a dean come into KU that wanted to grow programs if at all possible, so he was very supportive. I will say it's a tremendous amount of work to increase your class size by 50%. We went from 24 to 36. And since we admitted our first years in summer of 2021, this is the first time we have had 36 in every class. So we have 108 students in our program. That is a lot of students. We have a lot of clinical sites across the state. We are extremely proud of what we have been able to do to emphasize rural care. I have listed them for you and want to speak about that. We also have sites in Nebraska and Oklahoma, 1 site in each state, and of course we're in a bi-state area in Kansas City, and we do have several sites in Kansas City, Missouri, as well as Warrensburg and Clinton, Missouri. So in Kansas, our primary clinical site is KU Hospital. That is an academic medical center, and you would expect that. They are able to allow us to have 25 to 30 of our students in the OR every day. Obviously, we could not have 70 students in even a hospital as big as KU's OR. So we have had to expand our clinical sites, and we can usually send one student to each clinical site, sometimes two. The most are 3. Menorah Medical Center takes 3 of our students a month. So we have 108 students. Obviously, it would take a lot of clinical sites when you're sending 1 to 3 at a time. And if any of these facilities in the Kansas City area where we have the bulk of our training hired AAs and utilized AAs, our students would not be able to be in any of those rooms doing any of those cases. And we need all types of cases. We need cases that are basic to cases that are very complex. Our accreditors require that they have minimum numbers of virtually everything. Regional blocks, neurosurgical cases, pediatric cases, obstetric cases, they dictate this. To answer a question that you asked Carol Moreland about the clinical training, our accreditors did not allow this to change at all with COVID. Our students were taken out of the OR, and one of the most difficult things I have done in my role as chair was getting them all back into the OR. They were out an average of 2 months, some of them a little bit longer than that. I will say that the biggest obstacle was getting enough PPE for them and figuring out who was going to pay for it. The University of Kansas, as you know, is a state institution. We do not have money to buy N95 masks and half-face respirators and things like that the students needed to get back into the OR, so this was a gradual process to get them back into the OR. But we did that, and now everything is fine. We have enough of the personal protection that we need to take care of these patients. The other thing that I want to emphasize is that our students are registered nurses, and they have that critical care experience, and when COVID hit, they could function as registered nurses. If they were not needed in the OR because a lot of the elective surgeries were cut back, they could go to the ICUs where they used to work and help, and be even more help because they could intubate. They could do things that the registered nurses working, you know, as a staff nurse in that facility or in that unit could not do. So they were a tremendous help. And AA would have been of no benefit whatsoever in that scenario. They are not a registered nurse. They are not licensed to do anything like that. So I think that that emphasizes even more the importance of our education as nurses and our background in critical care. So going back to where we have students, we have them throughout the state. Lakin, Kansas, 2 CRNAs in Lakin, Kansas, and one is a graduate of our program and another is a graduate of the Newman program, and we send a student there. The 2 CRNAs in Ottawa, Kansas are graduates of our program. We have a graduate of our program in Atchison, where we send 1 student a month. There are students everywhere that are graduates of our program, and increasing our class size from 24 to 36 has probably benefited the University of Kansas health system the most. They have already contracted 16 of our current seniors, that's getting close to half the class, to start this summer after they graduate and pass boards. So they're hoping to hire even more of them, but again, the emphasis on rural Kansas. One of them has taken a job in Winfield, and Winfield is thrilled. They take our students. Another has taken a job in Warrensburg, Missouri, where we send 2 students a month. So again, we are very happy to have our students graduate and go to these communities such as Lawrence, Hayes, Topeka, Salina. Again, they are all over the state working and taking care of Kansans every day. I also just want to say that we have students in clinical and permanent clinical sites in Wichita and Topeka from Texas Wesleyan University. I know they have not been mentioned yet this morning. And then the Newman program. Again, the only facilities, the only areas in Kansas where AAs could be hired and work would be primarily Sedgwick County, Johnson County, and Wyandotte County. I have students at both hospitals in Topeka, at Stormont Vale, and at St. Francis. Those CRNAs in those facilities work with anesthesiologists but are not medically directed by anesthesiologists, and the AAs would have to be. That's also true in Salina, where we have students, in Hayes, where we have students. So AAs, even though we're talking about larger communities in the state, would not be able to work in those facilities. If they did, they would have to change their workflow and do the anesthesia care team model, medically direct AAs. That would require more people working because you would have to have the anesthesiologist supervising, medically directing the AAs, and they do not have to do that for the CRNAs. That makes a difference when you're taking call at night, going in for OB cases. It would increase the cost tremendously, and that is obviously not what we want for healthcare in Kansas right now. And I would be happy to address any questions.
Donna, thank you for your testimony, and we do have questions. Senator Baumgartner.
Thank you, Mr. Chair, and thank you for being here today. So I'm a little curious, were you notified ahead of time of the June 11th meeting where they approved AAs?
No.
So how did you find out about it?
I found out because I'm a member of the Kansas Association of Nurse Anesthetists, and we were notified.
After the fact?
After the fact.
Thank you.
Senator Gossage.
I asked a previous conferee regarding, and thank you, Mr. Chair, what's going on in Missouri. Do you have any indication? You said you work with Warrensburg Hospital as well. How this has been working with the CAAs?
Well, Warrensburg would not be able to utilize AAs. They have one anesthesiologist and many CRNAs, and they all work on their own.
Okay.
Yes, we have had problems with Children's Mercy Hospital. They have hired so many AAs that I checked yesterday, and they have 4 CRNAs and 11 AAs. Our students, and also a student from the UMKC program, an SRNA, are both scheduled at Children's Mercy every month, and frequently there are no rooms that they can go into because there are not CRNAs available for them to work with. Because they are not using AAs at the Children's Mercy Kansas site, they tend to send the CRNAs to that facility now. That's in Overland Park, and our students can go there. But pediatrics is a huge problem. It's difficult to get enough pediatric cases, and now we have 36 students in each program. And if we are not able to utilize the Children's Mercy site in the future because they simply don't have any CRNAs, then we are really going to be hurting for pediatric cases. I don't know what we'll do right now, to tell you the truth. In the Kansas City area, Liberty Hospital has hired AAs, and the last time I checked with them, they were down to 1 CRNA. When these facilities start hiring AAs, it tends to create a very hostile work environment for the CRNAs, and they don't want to be treated the same as another provider, the AA, when they are not the same. And Children's Mercy and Liberty and St. Luke's on the Plaza, this is what they have chosen to do, and they are really struggling to hire CRNAs. I will also tell you about Missouri State University in Springfield. Springfield anesthesiologists and facilities decided to start hiring AAs, and it got to the point that they had so few CRNAs that the nurse anesthesia program at Missouri State no longer has any clinical sites in Springfield. I can't imagine. I just cannot imagine having a program where every one of your students is out of town every day for clinical. It would be a really huge challenge getting enough clinical cases. So that has caused a big problem in Missouri.
So if I may, Mr. Chair, so to clarify, making sure I understand this correctly, if you have an SRNA, a student, and then they must be under the supervision of a CRNA for their clinical when they go into these hospitals.
Or an anesthesiologist.
Or an anesthesiologist, but of course they can't be under an AA.
Correct.
And I guess I'm trying to understand why we need AAs. I can't quite figure that out. So if you have an anesthesiologist, and it sounds as though from what we heard yesterday, they can oversee up to 4. We were told most have 1 or 2. To maybe broaden the number of patients that they can work with, but yet they have to have direct supervision. So again, I'm just trying to figure this out in my head. So a CRNA can oversee, or as much like a classroom teacher, I've been a classroom teacher, and we would have student teachers, and they would come in, and you would supervise them. The same kind of thing with the CRNA, and they would supervise them. So what you're saying is the reason you can't send these is they don't have enough supervisors. Is that what I'm hearing?
Yes, in a hospital like Children's Mercy, Kansas City, Missouri, yes.
Thank you so much. Thank you, Mr. Chair.
Senator O'Shea.
Thank you, Mr. Chair. You mentioned, it's required to have a doctorate program, and then just the requirements that are there. Who requires those? Is that the board?
The Council on Accreditation of Nurse Anesthesia Education Programs is our accrediting body.
Thank you. And is that, forgive me for my ignorance, is that statewide or nationwide?
Nationwide. There are now, I believe, 128 nurse anesthesia programs in the country, and they are the accrediting body. We're also accredited by the Kansas State Board of Nursing. For example, in 2019, we had our 10-year reaccreditation visit with the COA, and the Kansas State Board of Nursing also attended that to reaccredit us.
Another one, please. What does this issue look like on a national or federal level?
Alyssa could probably answer that more directly than I could. I know that I don't believe any state laws have been passed in states where this is being pushed, such as in Kansas, for a number of years. So it's been very stagnant. Texas, I know, has not been able to pass the bill either, but they also, their equivalent of their Board of Healing Arts decided on some delegation language. But I do not believe there are many AAs working in Texas because they're not licensed and certified there.
Senator Petty.
Thank you, Mr. Chairman. This kind of just follows up with some of the other questioning, but you mentioned about the doctorate program, and I know it became a doctorate program nationally, or everybody had to be a doctorate program in 2022, but in Kansas, was it 2015 when we first started, or have we been doing a doctorate program since then?
Well, the University of Kansas was one of the first 10% of programs to go to the clinical doctorate, so we're very proud that we were on the early side of that. But every program has now transitioned, including the Newman program in Wichita.
Okay, and then secondly, and this really is following up with what Senator Gossage had asked. So if a hospital has, and I guess Missouri is more of an example, has AAs, then CRNA or CRNA students cannot get any clinical in those operating rooms where the AAs are functioning under the supervision of an anesthesiologist. Is this correct? Thank you.
Okay, Donna, just kind of following up on the education part. KU was out in front in 2012, went from a certification process to a doctorate program.
50 years.
Yeah.
We were a master's program, obviously, before we were a doctorate program.
So when it was a master's program, what was the cost difference for the student going from a master's to a doctorate?
Well, it wasn't really much of a cost difference because before we went to the clinical doctorate, we expanded the program from 30 to 36 months because the technology and what was required just became such a burden to get in that short amount of time. So we had 3-year graduates of the master's program for several years before it became a clinical doctorate. So the cost difference at that time was really not that much. Now, when it went from the 30 months to the 36 months, that added about another semester, and I can't remember exactly what that cost was, and it was long enough ago that would probably seem like nothing today.
Thank you. And I do not see any further questions from any members of the committee, so thank you very much. Conferees, thank you. Committee, this does wrap up today's testimony. I do want to draw to your attention on the committee webpage, there was an updated committee report from the Special Committee on Health to the 2020 Kansas Legislature that is up there for your viewing. So be sure to look at that in your spare time when our board needs something to read. If we have nothing else come before the committee, we will be adjourned. Not seeing any.